My name is Professor Silber. I'm a cardiologist in Munich, Germany, and what we should talk is about acute coronary syndrome regarding to the new European Society of Cardiology guidelines. When we compare the guidelines for myocardial revascularization, the number of experts to find consensus almost doubled between 2005 and 2010. And this is also reflected by the considerable increase of number of pages. This shows you that things become more and more complicated. So what's important to know is that the definition of recommendation is fortunately the same. So the class of recommendation and the level of evidence have not changed. For those who say, I don't want to read 100 pages, look at the tables, look for the red color, which means class 3 recommendations, because you should at least know what is not recommended by the guidelines. So one of the major changes is the recommendation for who should get PCI and who should get bypass surgery. There are now more indications for PCI, like left main disease, at least with lower syntax scores. But the main topic is acute coronary syndrome, and let's start with STEMI, ST elevation myocardial infarction. There's a slight change of the wording in the guidelines. For example, the P2Y inhibitor should be given as soon as possible. Even paramedics could decide whether to give a P2Y inhibitor or not. The new wording says prasugrel 60 mg loading dose, 10 mg daily, if no contraindication. And for ticagrelor, it says 180 mg with 90 mg twice daily maintenance dose, again, if no contraindication. And actually, the contraindications to prasugrel are only two, previous stroke or transitory ischemic attack. And ticagrelor, the major contraindication is hemorrhagic stroke. So there should be an increase in usage of prasugrel and ticagrelor. If there's no contraindication, there is no place for clopidogrel anymore. Regarding intravenous or intracoronary antithrombotic treatment, the use of 2B3A inhibitor actually is a 2BB recommendation. Upstream use of glycoprotein 2B3A inhibitor versus in-lab use may be considered in high-risk patients undergoing transfer for primary PCI. What about anticoagulation for primary PCI in STEMI? Enoxaparin got intermediate recommendation 2AB for STEMI patients. It was not recommended in the previous guidelines. What's also new is the recommendation of bivalirudin for STEMI patients with a recommendation of prolonging the infusion after PCI because there might be an increased risk of stent thrombosis. So it is now recommended to keep up the infusion rate for up to 4 hours after the procedure. So in the first guidelines, we recommended after ACS a whole year of dual antiplatelet therapy. In 2010, again 1 year, and now in 2014, again 1 year. Now, this is interesting because actually we do not have many trials of monotherapy versus dual antiplatelet therapy. So all the recommendations of 1 year are derived from the old CURE trial. But what I see, the major problem is that many patients discontinue the dual antiplatelet therapy after 6 months. But for acute coronary syndrome, patients should have it for at least 1 year, independent of a bare stent or drug-eluting stent. Even if they had no stent, we have to make more emphasis that ACS is not over when the patient gets home. ACS goes on and has a higher risk than patients with stable angina. In patients with acute coronary syndrome with no ST segment elevation, there's a new class 3 recommendation, which means don't do it. Pre-treatment with prasugrel in patients in whom coronary anatomy is not known is not recommended. This comes from the ACOS trial. For the first time, it was tested whether pre-treatment with prasugrel versus no pre-treatment in these patients is helpful or not. It had only negative effects, which means more bleeding, but not preventing ischemic events. There are two questions with this. The first question is, should and could this be extrapolated also to ticagrelor? We do not have any data for ticagrelor in NSTEMI pre-treatment versus no pre-treatment. In our institution, we say this is the same for both drugs, so we do not do any pre-treatment. The second thing is, if you withhold prasugrel or ticagrelor, you give only aspirin and heparin before coronary angiography, patients usually should not wait longer than 4 hours or 8 hours for the cath. So what about pre-treatment with a 2B3A inhibitor? There is no change in the guidelines. You should not pre-treat NSTEMIs with a 2B3A antagonist before the cath lab or before you see a lot of thrombus. What about bivalirudin anticoagulation? For NSTEMI, there's a new recommendation which says bivalirudin should be used in these patients as an alternative to fractured heparin plus 2B3A inhibition, but also, and that's important to emphasize, do not reduce the rate of infusion after PCI, go with the same dose for the next 4 hours. In NSTEMI, the overall bottom line is that you should not pre-treat the patient, just give aspirin, heparin. The rest is decided in the cath lab after diagnostic angiography. And bivalirudin got a strong recommendation for prolonged infusion. 2B3A inhibitors should not be given in NSTEMI upstream. The recommendation in STEMI has not changed. The most important thing is STEMI means go to the next hospital with the cath lab. And of course, these hospitals should have 24 hours, 7 days a week service. Pre-treatment should be given at first medical contact. That is a challenge. The Atlantic trial showed that if the transportation times are very short, there was no difference in the primary endpoints between pre-treatment and no pre-treatment. So does that mean you should not pre-treat in STEMI also? I don't think so. If you have longer transportation times, prasugrel or ticagrelor should be on board of the emergency cars. What is to be expected in the future regarding ACS? How long should dual antiplatelet therapy really be performed? Well, usually we say 1 year and that's it. But if you continue dual antiplatelet therapy for 2 or 3 years or even 4 years, there might be some signs of a benefit. And this will be actually investigated in the Pegasus trial. And if this trial is positive, then this will change all our thoughts and concepts of how long to give dual antiplatelet therapy. So I think this is the most important thing in the next years to decide. For patients with stable coronary disease, dual antiplatelet treatment duration is limited to the stent and not to the patient. But ACS is different. And this is one thing in the future we have to emphasize. ACS is not over when ACS is over. Many people think, I got my heart attack, the doctor fixed it, and that's it. No, it is a dangerous disease with still an increased mortality, and we need more drugs to treat the following years after ACS.